Hi everyone, welcome to Making on Monday, and today we've got a very special guest. We've got Dr. Associate Professor Gavin Sacks, who is from IVF Australia. He's the clinical director at the Alexandria IVF Australia. He's also the director of clinical research at IVF Australia. And he's known for his kind of effective treatment of infertility of both women and men. And his patients really like him for his honesty and understanding, and also his determination. He's really well known for his natural killer testing research and expertise around reoccurring miscarriage. And so without further ado, today we're having a Q&A. So we're going to ask Gavin some questions, which we've had quite a few which have come through. So hi, Gavin. Anyway, thanks for joining us.
Hello, everyone. Thank you, Amy, for having a chat. I wish we were in person, but anyway, here we are on Zoom, and beautiful everyone to join us as well. Thank you.
Yeah. Okay, well, let's get started. We've got a few questions to start with. So the first one is, I think, a really good one to start off with because it's really nice and general. It says, how can I best prepare for egg collection?
Okay, yeah, that's a great question because I do have a very clear answer to this one. And I know some people aren't going to like this, but basically the best way to prepare is not to prepare and just like do what you have to do. Like, frankly, by the time you get for an egg collection, I mean, and I'm assuming the question's about, you've been through the cycle, you've done all the injections, the specialist has said, it's time, this is it. And like, there's nothing else to do. You've got to follow through the instructions. And the most important thing is do what you're told, like do the instruction. I actually, IVF Australia has an on-call like emergency line during the night, and we doctors have a roster system to hold that emergency line. And we get quite a lot of calls from people in the middle of the night. I've broken the needle, I've lost this, I'm not sure about that. So being calm and know what you're going to do for the trigger day, really important for the trigger time, really like that is a critical thing. And then, you just got to kind of go into today's surgery whenever, and you've just got to go through. So you do exactly what you're told. It's surgery, you do what the instructions say. And I don't think you should do anything else. There's nothing else you can do at that point, like to change the outcome. So I really encourage you to step back from thinking that you need to do something or that you can do something. It's really, you've just got to, it's like surgical procedure. You've got to do what has to be done. And so the best way is just follow instructions.
Yeah, sure. Yeah, well, that makes sense. Yeah. The timing of the medication's very important, I know. And I mean, following on from this is how to best prepare for an embryo transfer. Would it be pretty similar advice?
So yeah, again, the outcome is, I mean, people find this very hard to accept, I know, but basically the outcome is really about the embryo almost entirely, like almost completely the embryos that's going to determine the outcome. If it's genetically abnormal, it won't work, and if it's normal, it probably will work. Now, so what you got to do is just be there again, do what you got to do. And I see a lot of people worrying about so many things. Should they prepare this, that, take this? What can I eat? Can I drink? And actually, you've got to just get there and be calm and do what your doctors and the team say you've got to do. The second most important thing in the transfer success rate, in my view, is the doctor like doing the transfer. Like that's a really important thing. And
Yeah,
so
I know
you've got
you're
to,
very keen on the ultrasound, and so making
yeah,
sure it goes to
but,
the right spot.
well, whatever it is, no, you've got to
Yeah.
do whatever your doctor wants to do. Like that's that person has to be calm. So, stressing them out with a whole load of what about this and can I do that? Like, I'm not sure that's necessary because actually you want the embryo, that's just who knows what that's going to be. Then you want the to transfer the procedure to go really well. And that's,
Yeah, for
again,
sure.
out of your hands, but you just want to kind of go through it. I think in terms of how you can modify the outcome, that's almost like a mystical world of whatever, as I'm sure Amy would agree. There are many, many things that have been shown to be associated with better outcomes. And when I think about all those things, I'll just list some that I know of. Acupuncture is one, eating McDonald's fries, having a comedian in the room, doing mindfulness. Um, there's a long list of things that seem to improve the outcome in some studies. For me, the common factor is people being calm and happy. Now, how we achieve that is quite unique. And I really encourage everyone to not think that they have to do what other people have done. So the worst thing is to look on the internet and say, oh, this person said I need to get up in the morning and put on those socks and do whatever. Like, do what you want to do. And that makes you feel happy.
Yeah.
Uh, I had quite an interesting little fun time today. I'm sure many of you out there have heard of the McDonald's Fries Association with better outcomes.
Yeah.
Uh, and I said to
Yeah,
her,
that's been kicking around a long time, that one.
so I said
Yeah.
to her, look, why don't you go and have some Hungry Jack's fries? And when it works, then you can write on the internet, it's not about McDonald's.
Hmm. Just see what happens. Yeah, yeah, yeah. And I mean, I know that you're not big into Chinese medicine philosophy, but in Chinese medicine, we really, it's really important when people ask us what to do. We're often saying, do what you can do to kind of bring yourself a bit of joy in that
Yeah,
2 week wait, because there's not much you can do. Like whatever's done is done, right? Like similar to what you're saying. And from a Chinese medicine perspective, like the uterus and the heart are very connected, and so you want the emotion of joy to help there be like a nice sort of circulation of energy there.
I really
And
like that.
also to give people permission to not just to try not to be too worried or stressed, and do just keep enjoying their life. It's which is a hard thing to do when you're going through infertility, because of course, yeah, there's a lot riding on those results.
I really like that comment, Amy. Look for joy. We should do that always. That's what life should
Yeah,
be. And in fact, if you want to make life, then you should be living the life. And that means be joyful and find your own happiness, even in what might be suffering.
mm,
Life is life. So you've got to,
yeah.
and I think a lot
And
of the
it
the, the
keeps the
things
energy
about
going
the,
from a Chinese
yeah,
medicine, that keeps
no,
it circulating, which is
I'm
really important.
I'm I'm definitely bonding with that, Amy. That's where we're very aligned.
Yeah,
Absolutely.
yeah, great. And then another comment is, I mean, this is quite a technical question. What your treatment would be for OHHS, so over hyperstimulation?
What is my treatment for OHSS?
Yeah, that's one of the questions, which is
So,
quite technical because there's just a
no,
medication that's given.
no,
Yes.
OHSS, ovarian hyperstimulation syndrome, is almost close to being non-existent these days.
Yeah,
And
I've noticed that in the clinic from when I first started working in IVF 15 years ago. We
hmm,
saw a lot of OHSS. Like it happened,
yeah.
not a lot, but it did happen. I hardly ever see it
So,
now.
yeah, so it's officially about 5% of IVF, or used to be. Now it's less than 1%.
And that's
Uh,
because you give a different trigger now, isn't it? But if you
So
suspect it
no,
might be
no,
OHS.
there are many reasons why.
Okay.
One is planning the cycle and how we approach the drug dose at the beginning. Secondly, it's the protocol. So everyone now has what's called the antagonist protocol, or rather
Mm,
than something called the long protocol.
yeah.
And that protocol itself, just the dynamics of it means it has a lower chance. Then
Mm,
we come to the trigger, and when people are overstimulating, or when we're worried there's going to be lots of eggs, or the estrogen levels are very high, we decide to give a different trigger. We give something
mm,
called decapeptyl rather than Ovidril, and decapeptyl kind of switches off very quickly. So it makes the eggs mature, which is the important thing, and then it switches off the hormones. So the whole syndrome gets turned off very quickly. Of
mm.
course, that's only possible to do when we freeze any
Yeah,
eggs
because
or
you can't
embryos.
transfer that cycle
Yeah.
because the progesterone
So, yeah.
down.
So basically, OHSS has been almost eliminated because of those approaches, which kind
But
of
how
means
long has
a lot of people are ending up freezing,
for
whether because for safety or actually because they're doing things like PGD, testing
mm,
embryos. So a
yeah,
lot of people are freezing anyway, but
yeah.
that's rare to get it.
And how long have you been using the decapeptyl, trigger? Is that only
Oh,
about 5, 10
no, no,
years, or has that been
yeah,
longer?
no, 5,
Yeah.
less than 10 years, less than 10 years.
Yeah, because that's what I think I've noticed. So since that triggers come in, there's ha we hardly
Hardly
ever see
any,
it. We hardly ever
hardly
see
any.
it now, and I think
But just
previously I saw it a lot more.
Just to answer the question, though,
Yeah,
there is no treatment of OHSS. So once you get it, it is a bit of a problem. So
yeah,
there's no actual way we can treat it apart from watching, giving you blood thinning medication to avoid a thrombosis. Um,
mm,
Often you need pain killers support in the hospital. You get very bloated. You have to drain fluid from the abdomen, but it's supportive care until it gets better. It always gets better,
mm,
like always.
yeah,
So sometimes can take a few days, sometimes weeks when it's really severe, but it
mm,
always does get better. And sometimes it ends up with a baby, like pregnancy can stimulate the symptoms, but the OHSS goes away and the baby carries on. So, it's I don't know, the outcome ultimately is often good, but most women hate it like it's a terrible thing. So it's
mm,
definitely something that no one wants to have, but
yeah,
it's very rare these days.
yeah. Okay. And then we've got another question, which is just, I think, about IVF. So it sounds like this person's just getting ready to do IVF, so they're trying to find out everything about it. And is what can I expect from the medications, the IVF medications?
So if it's the antagonist protocol, which is what I mentioned, which is the commonest one, most people have that these days. It's
Yeah.
like the short protocol or like 2 weeks, starts when the period starts. I think you can expect almost no side effects at all. Like I think
Mm,
you should have high expectations to carry on normal life. The injections don't give you any symptoms. They are the same hormones that your body makes naturally, just a bit more of them. So you don't
mm,
feel bad. You don't feel anything apart from the stress of doing the whole thing and, you know, having the phone calls and blood tests, which are stressful. But basically,
mm,
the drugs don't do anything. And
yeah.
then towards the end of the cycle, your ovaries are big, you hope,
Mm,
full of follicles, and then you feel pressure, pelvic pressure and kind
yeah.
of bloating just right at the end, last 2 or 3 days maybe. So minimal. I'd expect life to carry on, work and everything you normally do.
Yeah. Okay. Thank you. So the next question we have is around how accurate are the PGT tests for someone who's going through IVF with a balanced translocation? Another very technical question.
Well,
And
technical.
there's also a follow-up question: what are the live birth rates for natural pregnancies versus IVF for balanced translocation carriers?
Um, okay. First of all, testing the embryos is where you biopsy, you take a few cells from an embryo, test the
Mm,
cells on the outside for their chromosome makeup. We call it genetic test. It's a chromosome test. It's quite a crude test, really. And then the embryo is frozen and kept, and we get results. So we normally do that because most embryos fail because they are abnormal in that particular way. So most embryos fail. When they fail, they have abnormal chromosome numbers. We all have 23 pairs of chromosomes. That's what humans have. And because of the way eggs and sperm are made, sometimes there's an imbalance. If
mm,
there's extra chromosome or missing one, it's not going to work, or you'll have a
mm,
miscarriage, or sometimes an abnormal baby. So
mm,
the test is pretty good. We would quote 98% accurate.
mm,
98. Nothing's
yeah,
100% in life. Like if you imagine the complexity of what's
mm,
involved in taking a sample but
yeah,
it's, we say 98% in IVF Australia, but in fact, the true technical accuracy is more than that. It's better than that.
mm.
Now,
And has
translocation,
that testing improved over time?
yeah, um, I mean, look, PGD was first done like 30 years ago, so huge
Mm,
advances in
yeah.
uh, the way we do the genetic testing. Now, translocation, just for your listeners and your questioner there, That's where the chromosomes are arranged in an abnormal way. So the person's abnormal and is normal, but the way he or she have their chromosomes arranged, one chromosome is attached in a different place. And what that means is when eggs and sperm are made, they're more imbalanced, in sperm or eggs. So much higher chance that any embryos are abnormal. So they're a classic sort of situation where PGD might be a good idea because they
Mm,
will produce a lot of abnormal embryos.
yeah.
So it is a good thing in theory, but it's very fair to say it's not always the answer for everyone. Um, every translocation that everyone has is unique. So your listener there will have he or she her own thing, and that's impossible to know exactly what the consequences of that translocation is. Some people
Mm,
have a translocation and never know, and they have families and stuff, and they never
yeah.
really know at all. Some
Mm,
people, you see it by chance, whatever, and they might do PGD, IVF PGD, and it never seems to work. And then they suddenly get
mm,
pregnant naturally.
yeah.
That does happen. So it's hard to assess the real actual consequences of a particular translocation. And
Mm,
natural conception, natural success is definitely a possibility for many of them.
mm,
Hard to put a number on that, though.
okay.
That's quite a unique to that particular problem.
And there's a final follow-up question around this, which is what are the risks to embryo with genetic testing, and what happens to the embryos which
Yeah.
cannot be tested?
So, it's PG is a complicated thing to go into. I don't tend to, I don't personally recommend everyone to do it, and I certainly
Mm,
don't push people into it without some sort of discussion because PGD doesn't make the baby. All it is testing. So
mm,
it's only by its very nature is only harmful. You're not actually improving anything. And a
yeah.
biopsy of an embryo is risk. So we think that about 5% of embryos could be affected by the biopsy, whereas,
Mm,
it's not a small number. So you
yeah.
could have an embryo tested. The embryo is affected by the biopsy. Maybe it doesn't survive, or it's affected in some other way,
Mm,
and it's a normal embryo and it won't work. So that is possible.
mm,
So we go into it carefully. And then the other point of your question was, there are some embryos that are not suitable for biopsy. So the embryos have to be a really good grade to get to that point to biopsy safely. That
mm,
doesn't mean that they're necessarily an abnormal embryo. Um, so sometimes you can, I believe, lose out by going through the kind of process and we're looking to biopsy, and when we can't, you kind of end up discarding embryos. It gets quite tricky.
mm,
So it's something to go into carefully, and not always first line in IVF. Depends on the problem, but
mm,
in ordinary IVF, I don't recommend it first line.
yeah. Okay. Thank you. Um, and then we've got these are kind of some of the final questions. We have, what testing or protocol should I consider doing IVF with a diagnosed autoimmune condition like rheumatoid or um, psoriasis or
Yeah.
arthritis?
Um, so an autoimmune condition doesn't necessarily mean anything different for fertility. I know there's a underlying concern, which is fair enough. But actually, most women with autoimmune conditions just get pregnant and have children. Like, it's not a clear cut thing at all.
Mm,
So, uh, like for example, rheumatoid, I'm not sure that has any specific effect on fertility. Um, there are and arthritis, I don't think it does. It's tricky because it's possible that there is also an association between those conditions and fertility. The association will be through antibodies, which are these immune factors. Uh, Autoimmune conditions vary quite a lot. Depends on what your exact thing is.
mm,
So anyway, my first thing to say is basically look at the whole fertility picture because it's not really like I see a lot of patients who come with that kind of thing
Mm.
And the first thing is just forget the condition and
Yeah.
focus on all the other fertility things, like the sperm test, for example, and
Yeah.
other anatomical problems and the egg count and things like that. Um, in terms of approaching IVF, again, most of the time I would really say approach IVF just like anyone. It's really hard to just say you need some kind of immune therapy. I'm wary of that as a
Mm.
kind of first line thing. We don't really have enough evidence to suggest you need
Mm.
automatically immune therapy. There is this test that Amy, you mentioned before, called natural killer cell testing. This is a probably abnormal test is associated with autoimmune conditions, and it's probably the closest test we have to a fertility immune test. Like,
Mm.
so it's designed specifically for infertility and IVF,
Mm.
and if the test is abnormal, you're more likely to fail in IVF, and immune therapy might be warranted. So if you have an autoimmune condition, you could say, well, should I do that test in addition to the other things?
And is it something when you see people clinically and they tell you like they've got a history of autoimmune condition, is that something where you'd kind of go, oh, maybe we'll do this test? You'd think about it? Or would it
Um,
be more like if it was, side by side with the other signs and symptoms, things like they've had, like lots of, I don't know, they haven't been able to conceive and they seem to have been making, good
yeah.
embryos
So,
previous or things
yeah,
like that?
so it's another indication. Yeah. So
Mm.
people who've failed a lot and miscarried a lot, and some people will be concerned that they have an autoimmune condition. Do the
Yeah.
test if you can.
Yeah.
It's not such a widely available test, but do the test if you
Yeah.
can.
Yeah. I've certainly seen patients where they've sort of tried everything and it just hasn't worked, and it's because they've had an immune, this is
Yeah,
what's happened, and then they've done the natural killer cell testing and protocol, and that's what's really helped them.
yeah,
But obviously only going to help them if that's what they need. Yeah.
yeah.
So, okay, that's really interesting. We had a couple of more questions come through. Do you have time for a couple more,
Sure,
Gavin?
sure.
Great.
Yeah.
So it says, on your IVF success website, it says my chance for a live birth from first complete egg retrieval is about 20%. I recently did my transfer and it's positive, but I'm at 4 weeks now. Does that mean my chance of a live birth is still 20%?
No, it's higher now. But
Yeah.
so at 4 weeks,
So,
um, well, if they told you that it's a good level, the hormones, then you're definitely probably over 50% at this point.
yeah. Okay,
So,
good to
and,
know.
and
Yeah.
if you get to a scan, so in another 2 weeks, you might have an ultrasound scan, and if that shows a heartbeat, then you'll be up to like 90 to 95% by then.
Yeah, great. That's good to know those statistics. And how much does PGD testing, sorry, reduce my chance of miscarriage?
Oh,
So I
tricky
think
one.
that means if they
Yeah,
do
yeah,
the testing and they
yeah,
have
yeah.
like the
That's a good.
embryo is PGD okay?
It's a good
Yeah.
question. It's never been proven in terms of
Oh,
scientific
okay.
evidence to prove that it reduces miscarriage rate. We sort of assume it does. We often observe it does in trials, but to actually prove it has not yet been done.
Mm.
Look, it's a real, it's a real,
It
it's a
improves your
real.
chances of a live birth though,
What,
doesn't it, with
what I
PGD
can say,
embryos?
what I can say is this: if you get pregnant with a PGD embryo,
Yeah.
the miscarriage rate in IVF Australia anyway is like about 3 to 5%.
Mm.
Whereas if you get pregnant with an untested embryo, so just any pregnancy or IVF without PGD, the miscarriage rate's like 15 to 20% on, 15% perhaps. So
Yeah.
PGD does seem to reduce it by whatever that is, nearly five
So it
times.
improves live birth rate.
It improves live birth rate per transfer,
Mm.
but not necessarily. Yeah. So it improves. So once you've had the transfer, but so the reason I'm speaking like this is many people go into IVF to do this and they don't have a normal embryo at the end. So
Mm.
And so they can go through the IVF and they test the embryos. It's not nothing, no
Yeah.
abnormal one, so they don't have a transfer. So that's
Mm.
part of a statistical analysis, you see.
Yeah, sure.
So it improves live birth rate if you
Have an
analyze it per
embryo.
transfer,
Yeah. Okay.
but only that.
Yeah, great. Okay. Okay, well, I think that's it. I think that's all the questions we've been given tonight. But you've given some quite technical ones, so thank you for taking us through all of that. It was interesting to hear, how you weigh these up and some of the statistics around it. I think it's been a really informative session for people who are either just starting on IVF or looking to just find out a little bit more and literally pick your brain. So thank you very much
Pleasure.
for being so generous and spending some time. And yeah, we really appreciate having you on, Gavin.
Pleasure. Beautiful, Amy. Thank you for inviting me. Thanks everyone for coming, and thanks for all your interest. I encourage everyone to seek real people like us. The internet can be really tricky
Yeah.
to kind of interpret, and obviously that's what I spend my whole life doing. So it's hard for you to catch up and do all that yourselves.
Yeah, for
So
sure.
thanks for coming to a thing like this. It's great.
We've been given some great insights today. So thank you. Thanks very much.
Okay.
All right, we'll leave it there. Thanks so much, Gavin. Everyone have a great night.
Thank
All
you.
right.
Bye now.
See ya. Bye.